Spontaneous branch retinal artery occlusion secondary to retinal artery macroaneurysm.
Good evening, everyone. So I'll be starting the next case presentation of branch retinal artery occlusion secondary to retinal artery macroaneurysm. So before starting the case, the RAMs are round of fusiform dilatation within first three branches of retinal artery, which is usually found in women in third decades and are associated with hypertension, atherosclerosis, or hyperlipidemia. And there have been very few reports of branch retinal artery occlusion secondary to RAM. So with this, I would like to start the case to diagnose and understand the association of branch retinal artery occlusion secondary to RAM. So a 70-year-old male from Visakhapatnam, Andhra Pradesh presented with chief complaints of right eye painless blurring of vision since morning. He was a known case of coronary artery disease since 7 years and was using tab ecospin for the same. So on ocular examination, his best corrected visual acuity in both the eyes was 20/20. He was pseudophakic in both the eyes with an IOP of 16 millimeters mercury on GAT. So on posterior segment evaluation in the right eye, as we can appreciate, the media is clear, the disc margins are well defined, and with a cup disc ratio of 0.3:1, and there is retinal whitening along the superior vascular arcade, and also there is a dot hemorrhage inferotemporal to the fovea. And if you look closely, there is an orangish lesion superior to the optic disc at the level of the retinal arteriole, which is suggestive of a retinal artery macroaneurysm. The left eye posterior segment examination was unremarkable. On FFA, as we can see that there is delayed arterial filling in the superotemporal side, and there is also a hyperfluorescent lesion superior to the disc, which is increasing in size and intensity, suggestive of leakage, while the left eye FFA was normal. And in the vertical line scan OCT of the right eye, we can see that there is increased retinal thickening, and also there is increased choroidal thickness as well. While in the left eye vertical and horizontal scan, the OCT finding was normal. And also in the hemi visual field test of 24-2, it shows there is presence of inferior visual field loss, while the left eye hemi visual field was normal. So the BP of the patient was checked and was found out to be 160/80. So with this, a diagnosis of both eyes pseudophakia with right eye branch retinal artery occlusion secondary to RAM was made, and a cardiologist consult was done when the patient was started on antihypertensives along with anticoagulants, and along with this, right eye eye drop timolol was also started for the patient. So after 1 month, the visual acuity was 20/40 to 20/20 parts in the right eye, and there was resolution of the retinal whitening in the right eye. And the FFA also showed normal arterial filling in the superior arcade, and also the resolution of the RAM, as can be appreciated. And also in the line scan, vertical line scan, as we can see in the vertical line scan, there is retinal artery, there is retinal thinning. So with this, I would like to conclude that BRA occurred to secondary to the thrombotic course of RAM in our case, and it is highly necessary to get delayed cardiovascular assessment, as RAM is associated commonly with systemic hypertension and atherosclerosis. Thank you.
Just put on the last slide. Last week. Thank you.
Okay.
So what do you think if I say it is RAM plus BRA?
But
Can you say it is RAM plus BRA, or you have to say RAM secondary to BRA secondary to RAM?
It can be because BP was raised, so it is RAM with BRO. And why, if there was a leaking macroaneurysm and you are suspecting that it is causing the BRO, why it was not lasered?
it was not.
It will not resolve spontaneously.
Because we were looking for the natural course of the RAM, like the thrombotic and the fibrotic and the resolving stage of the RAM. So we had called the patient after 1 month to look for the progression, like how will it respond. So that is why.
If it can spontaneously thrombose, that's okay. All RAMs need not be lasered.
Yes, sir, but if they are suspecting that this arterial occlusion
main
is
finding was whitening.
whitening.
Whitening of the upper
Yes.
temporal retina.
Can you go back to the first angiogram?
It shows delayed filling of the upper temporal vessel. No, I think that there's no need of any treatment in this. There's no need of any
It's a very interesting case and very well documented.
Can
Also.
we call this RAM plus BRAO or RAM BRAO secondary to RAM?
There have been like
Can concurrently occur, no?
both can concurrently occur, but
So how is your reaction if I say this patient has RAM plus BRAO?
that can also occur. But the RAM that is there, that is causing an occlusive effect over the arteriole and leading to the BRO occurrence.
So in any case, RAM structurally is a structure. Does it disappear like you have shown? RAM disappears.
It usually takes 3 to 4 months for the RAM to spontaneously regress, but in this case it regressed within 1 month as we called the patient, so that was unusual in this case.
How can we differentiate from plaque and ram and plaque? It can be the plaque might be causing the BRM.
You should have blown up the picture there. Where the microaneurysm, macroaneurysm is there. It's very interesting. It can coexist. Can you blow?
Uh, if
FA?
you-
FA? Actually see that the aneurysm is not filling up. See that? It's already thrombosed. The thrombus is already, or the whatever is in there is already there. So that itself might be causing a retinal artery occlusion. Sorry, branch artery occlusion.
yes, sir.
Very good angiogram. Very nice.
Very nice. Very nice case.
Can I just have one comment? Can that be a venous macroaneurysm also causing an adjacent thing? And just to point an answer for a laser too close to the disc, and for BRAO, if we're going to laser on an artery, probably it will itself lead to a BRAO. So probably we would not have done a BRAO. And just a question over here: can this be a venous?
Venous aneurysm will not have
This become
close the artery.
Close the artery. That
Okay,
can't.
close the
That
artery.
cannot close. The artery has a more resilient wall as compared to the vein, so it cannot compress things.
Just because the artery occlusion was there, so we were suspecting, like just prophylactically we started the patient on anti-glaucoma medication.
The fovea is very nice, and even if you had treated the macroaneurysm by anything, the vision would have been the same.
No, actually, I agree with him that I don't think so in a patient who has improved the vision, prophylactically use of Dorzox or but all of us do give in patients who have CR.
Maria,
Mm.
can you come here?
Six vision.
Yes, sir, I agree with that.